And now it's my great pleasure to have in the podium Professor Sylvia Mechsner, who is one of the very few professors of endometriosis. We are very lucky to have her, and she's going to talk about endometriosis-associated ovarian cancer and its clinical implications. Sylvia.
Thank you so much for this kind introduction. It's a pleasure for me to be here. And as a benign surgeon, it's a pleasure for me to talk to you more malignant surgeons.
No, we are also benign.
Yes. So, yes, you all know endometriosis is a severe disease, and there's patients with endometriosis have a lot of problems. The main problem is, of course, the pain, also chronic inflammation, fibrosis, and a possible malignant transformation of the lesions. The idea of this is not new. Already Samson told or described this 100 years ago. But now it's an upcoming interest on this topic. It's very interesting that you can see there came out a lot of publications about this. The data are very interesting. So there came data about the relation between endometriosis and cancer in general, for example, non-malignant Hodgkin lymphoma or breast cancer or melanoma or whatever, and also a connection between endometriosis and ovarian cancer. But these data based often on retrospective register studies, and that was the reason that the group of Stacy Mechsner worked on this systematic review and did a meta-analysis about this. Stacy Mechsner is one of the leading experts in the field of endometriosis, epidemiologist she's working in Harvard, together with other experts in the field of endometriosis, they worked on this. And they reviewed all these publications looking for accuracy, looking for data and so on. And of course, they found a lot of interesting information, but also a lot of bias. At the end of the day of these publications, she summarized that only ovarian cancer and thyroid cancer has a real interaction with endometriosis, a real association with endometriosis. As you can see here, this is very, there is an evidence that endometriosis is associated with ovarian cancer. And that is the topic today. This analysis showed us that especially the endometrioid ovarian cancer and the clear cell cancer is associated with endometriosis. We know that already. And the other histological subtypes are slightly associated, but there is no hard evidence for this. It is, but also it is well known that both diseases are very highly inflammatory diseases and share a lot of similar microenvironmental changes. So we have the endometriotic cells outside of the uterus, and so we have a lot of inflammatory cytokines. We have the loaded, hemosiderin-loaded macrophages, tumor-associated macrophages, neovascularization, and so on and so on. So both diseases share a lot of inflammatory pathways here. And maybe it could be also be by accident that both diseases but develop together. Yes, lesions are interesting. Endometriotic lesions are interesting. They have also the possibility of epithelial mesenchymal transformation, fibroblast mesenchymal transformation, smooth muscle metaplasia is present, and also fibrogenesis is present in these lesions. And we know also cancer driver mutations then are present, especially in deep infiltrating lesions. So that is also very interesting that are interesting changes for a benign disease, yes? And so we often discuss this ability of endometriosis for this invasive growth that is not typical for benign diseases. This publication looks from the patient's perspective, and I think this is very interesting because this Finnish discharge register was able to define 50,000 endometriosis patients, and they divided them into ovarian endometriomas with 23,000 patients, peritoneal lesions 20,000 patients, and deep infiltrating lesions 2,300 patients, and analyzed them separately. And they found a 3 to 3-fold increased risk for the development of ovarian cancer, so they confirmed this data. And the histology was an endometrioid and clear cell cancer. Borderline tumors were also significantly elevated, and there was also slightly increased risk for serous ovarian carcinoma. The ovarian cancer risk was highest in the group of patients with endometrioma. It is also in agreement with this finding, and the increased risk started from 5 years after endometriosis and from the age of 30. So, but the overall risk of ovarian cancer was not increased among endometriosis patients with only deep infiltrating lesions and peritoneal lesions. The risk of endometrial cancer was not altered in this population, but I think there are also controversial data available, but that is not the topic today. And the risk of precancerous cervical lesions is lower. That might be due to painful intercourse and lower number of sexual partners, maybe. That is also in agreement with other studies. However, the absolute excess risk of an ovarian cancer was small. So we had 1 excess case per 1,000 patients with endometriosis in general, and 2 excess cases per 1,000 patients with ovarian endometriosis. So talking about endometriosis-associated ovarian cancer, the endometrioid and clear cell ovarian cancer, they typically were diagnosed in an earlier stage with lower grade lesions than non-endometriosis-associated cancer. And yes, of course, the development of endometriosis is per se non-normal. It's also a pathological finding. And this might be due to epigenetics and genetic factors. But then the promotion of these lesions into the different kind of endometriotic lesions depends on environmental factors, angiogenesis, oxidative stress, immune dysregulation, and also genetic alteration. And then maybe sometimes the atypical endometriosis is present, and this could be then a progression into the endometriosis-associated ovarian cancers, but also triggered by epigenetic and genetic alterations. So these are the key players here, I think, the genetic alterations, inflammatory processes, oxidative stress, hemorrhage, and estrogens. What do we know? So the clear cell and endometrioid cancers, we have a lot of genetic mutations, as we know that, and we know also that some of them are different somatic mutations also in endometriosis, especially the ARID1A mutation with the loss of the expression of BAF 250 is well described. This is a nice case with all types of lesions in one patient, the distant endometriosis, but also the atypical endometriosis and the clear cell carcinoma. And as you can see on the right side, the BAF 250 expression is present in the well-differentiated endometriotic lesions, but there's a partial loss of BAF 250 in the atypical lesion, atypical endometrioma, and then a complete loss of this expression in the clear cell carcinoma. So that is nicely documented that there's a connection between the BAF 200 or the ARID1A mutation. Interestingly, I think also it makes sense that in case of unopposed estrogen, there's a reactivation of old endometriosis lesions possible. We know that because when patients underwent hysterectomy and they get estrogen replacement therapy, then they came often back with typical endometriotic-associated symptoms. That is not new, and we know that also from case reports about malignant transformation, for example, also of deep infiltrating lesions, that especially these patients had taken unopposed estrogen. Another point is the inflammation, the oxidative stress. And this is more related to the development of the clear cell carcinoma. Yes, also for the benign surgeons, the endometriotic experts, the oxidative stress is of interest, of course, because of the inflammation. And Professor Vicellini is one of the leading experts in this field also, and he explains this very nicely, the cascade of the oxidative stress and a possible interaction and transformation then in malignancies. And I think this publication coming out recently, and I think it is very interesting because this group tried to identify iron metabolism related predictive markers. They looked for the genes associated with the iron metabolism, and they looked in endometriosis and also in ovarian cancer, and they found 7 overlapping UP genes associated, and 3 of them they calculated also predictive model because 3 of them are present in both diseases. So that is maybe interesting for the future. But the next step of this group was also research for drug targeting, and they found that these 7 UP genes are maybe positively modulated by coenzyme 1, ascorbic acid, metformin, iron, and zinc. So some substances working anti-inflammatory, and maybe that is helpful also in addition for these patients because it's easy to add. Another point we need to clarify is, of course, the involvement of the hormone replacement therapy in this pathogenic process of malignant transformation. And this investigation is also really interesting, I think, because they looked for endometriosis, for women with endometriosis or de novo endometriosis or history of endometriosis, but postmenopausal women. And they divided them into 2 groups. 10,000 women received hormone replacement treatment and 10,000 of them not, and they didn't find any significant differences between them and the development of ovarian cancer. So that is a good information, I think, but due to sub-analysis and so on, they saw also that the estrogen monotreatment is, of course, a trigger for the malignant transformation, of course, and that is for us very important to keep in mind always, not for you, I think you are experts, but we need to bring this information also into the common mind of the gynecologist. That is very important. So we can give patients with endometriosis hormone replacement therapy, but a combined one. Another point I think it's very interesting is the previous artificial reproductive therapy. That is also something very often happened for patients with endometriosis. If there's a correlation or a relation with the development of cancer. And as you can see here, most of the other reasons for the people with infertility, others shows no risk of cancer, but the endometriosis group had a risk of cancer. But also here, and that is also very interesting information, I think, is that only the patients underwent unsuccessful reproductive treatment suffer from a higher risk of cancer, and these with pregnancy lost this risk. So in these patients, the risk was similar as in these other patients. Yes, also this, I would like to show you also this study, because that it was a retrospective cross-sectional study, but they treated nearly 500 patients with endometrioma. They did an excision of the endometrioma, and then they observed them. And they didn't give them hormonal treatment. So they had a recurrence rate of endometrioma of 25%. That is the normal risk of recurrent endometrioma without hormonal treatment. We know that it's absolutely necessary to give the recommendation of hormonal treatment after endometrioma excision. But here, for us, it's interesting because 4 of these patients developed ovarian cancer, and all of these cases were based on a recurrent endometrioma. So that is also important to know for us. Because now there is the question if there is a possibility of prevention of endometriosis-associated ovarian cancer. The overall risk of the development is small, but we know that atypical endometriosis is like a premalignant lesion, and it's most present in endometrioma. And as we know, the recurrence risk of endometriosis is high. It's easy to give them oral contraception and progestogen-only pills to reach therapeutical amenorrhea and reduces significantly the risk of recurrent endometrioma and also the risk of ovarian cancer. I think that is a possibility. Then another point is if there is a risk reduction possible due to complete excision of lesions. Also, this is a nicely done study, but also retrospective one from the National Swedish Register. They looked for 220 patients with endometriosis and ovarian cancer and matched them with 400 individual controls, only endometriosis patients, and looked for age, therapy, the surgical procedures, radical operative surgical procedures or hormonal treatment, and so on. And the result of this investigation was that there is a risk of reduction in case of complete resection of all lesions in 30%. That means number needed to treat 95 surgeries to avoid 1 ovarian cancer. Or in cases of salpingo-oophorectomy, it's more impressive. They need to do 62 surgeries to avoid 1 ovarian cancer. So there is a clear connection, that is true, but the lifetime risk of ovarian cancer, the development of lifetime risk is low in general and also low in endometriosis. So what should we say now, the patients? We need to avoid to bring them in an upset situation that they have so much anxiety for the development of...
Slam ist da. Hier, schmeiß die rein erstmal hier. Wir nehmen sonst einen Karton. Ja, okay.
Because overprotective procedures like oophorectomy might be a very radical prevention, but on the other hand, then we have maybe an early onset menopausal women who are premenopausal, and that brings other complications, as we know that there's an incredible increased risk for cardiovascular diseases, and that is also associated with high mortality in menopausal women. So for this, the group Mechsner and Kvaskov created this comment in Lancet. Please have a look. It's interesting because we all need to find our own way to give them the right recommendations, not to be over anxiety about the development of endometriosis, but also to be aware that there is a risk. So for this, another group looked for diagnostic markers, and I think that is also a very interesting study for all of us, because they looked for CA1 19 and CA125, and looked for combinations, and also HE4 is involved. And finally, they say patients over 42 years, large ovarian tumors, and in this situation, CA1 99, yes, 99 and H4 are valuable markers in this situation, and for the diagnosis of endometriosis-associated cancer, together with sonographic findings. So my coming to the end of the speech, the take-home message is keep in mind the history of endometriosis, but be careful when patients came to you the age of 45 without pregnancy, maybe ask for unsuccessful IVFs, postmenopausal status at endometriosis diagnosis, larger sizes of endometrioma, atypical endometrioma, use the biomarkers and look for hyperestrogenism in these patients and avoid this, and of course no estrogen monotherapy in patients with a history of endometriosis after hysterectomy. But altogether, I think it's absolutely necessary. It's an interesting topic, but we need more prospective data. Thank you so much for your attention.